Good afternoon, everyone, dear chairs, dear audience. Welcome to my complex exam presentation. My name is Kata, Haba, and my PhD topic is about the oral complications of type 2 diabetes mellitus. I am a third-year resident at the Department of Prosthodontics, Semmelweis University. I have two supervisors, Daniel Vég and Dóra Haluska. My SMS is Szenzinyi. My statistician is Gergely Agócs. My vision is to improve the life quality of patients with diabetes, and my mission too is to detect all the potential oral complications and target them. Currently, I have two specific goals at CTM ongoing. I started both of them in 2023 autumn. Let's see my first one. This is about the correlation between salivary and blood glucose levels, and I'd like to achieve it through a systematic review and meta-analysis. My co-investigator for this project is Patrick Reuter. Little background to it. Diabetes mellitus, a chronic metabolic disorder, affects many organs in the human body, including the oral cavity. And there are many million patients with DM, and its number is actually rising, who have to endure the inconvenience, pain, and cost of measuring the glucose levels from blood samples on a daily basis. Therefore, our aim was to detect a potential new method based on saliva for glucose level measuring in a less inconvenient way if possible. We chose our clinical question, that is, what is the relationship between salivary and blood glucose levels after fasting? Our framework for that was a PERT framework. Our population was a general population, including hyper and normoglycemic patients. Index test was saliva test based on glucose oxidase method. The reference test was blood test, and the diagnosis of interest would be the correlation itself. We hypothesized that the salivary glucose level matches blood glucose levels after fasting, and again, my clinical implication was to detect a new method for glucose level measuring if possible. Here you can see my search key below. I did my first search on the 22nd of November on 2023 in 4 databases. And here you can see my flowchart of selection. We included 25 articles at the end of this process. I have all my analysis done. I have 4 plots, and I'd like to show them to you. So on my first one, it visualizes the correlation between salivary and blood glucose levels from mixed saliva samples based on individual patient data. As you see, it has many colors. Each color represents one study with linear regression line and a coefficient of determination. And in the background, you see colors like green, yellow, and red. The green represents the normoglycemic range, yellow is for impaired fasting glycemia, and the red one is for the diabetic range as well. What's more important in these studies is actually the mixed model, the pooled mixed model that you can see with this thick black line in the middle of my scatter plot. And it's R-square value, which is 0.05, quite low, not what we hoped for. We hoped for a much significant correlation between the two values. So we went back to the literature where we found that maybe if we check the correlation between salivary and blood glucose samples, where the salivary samples were isolated from periodontitis saliva only, it could give us a much higher correlation. And yeah, it was higher, it's 0.11, but still not what we hoped for. I have to mention that we could extract, in this case, the IPDs only from 3 articles, and the newer ones, like the work of Sui et al., shows more promising results regarding this method. And this is my first plot. We compare the mean differences of salivary glucose levels in milligram per deciliter with random effects model. The overall effect size was 4.46 with a 95% confidence interval, which is statistically significant but clinically not relevant. And the heterogeneity is actually quite high, 100%. And we did the same for blood glucose levels as it was contained in the articles we included, and we wanted to see if the basic methodology that we know is true actually gives us the values that we are expecting, and yes, it does. So for strength of our study, I'd like to mention that all my articles included have well-described methods regarding the sample taking for both tests, saliva and blood tests, and they enrolled big number of patients into their studies. However, only a few articles included IPDs that were more informative for us, and some articles do not mention important health data that could potentially influence the measurement itself. And the sample storage methods weren't unified, which is a big limitation, actually. So for conclusion, we could say that blood glucose level measurement is still irreplaceable, and we do not recommend to use salivary glucose levels instead of blood glucose levels. And we implicate for research to target the potential influencing factors and develop a standardized methodology for estimating glucose levels from saliva samples as they are needed if possible. On this slide, you see my first project's progress. I did my manuscript writing, so I'm finished with it. And we submitted into our 5th target journal on the 21st of April, which is a Journal of Evidence-Based Dental Practice, and it is under review. Let's see my second topic, which is about evaluating oral hygiene and periodontal complications in patients with hyperglycemia. It's also a systematic review and meta-analysis. My co-investigator for this project is changed. It's Bulcsú Bence. Background. Investigating link between periodontal health and hemoglobin A1C level, which is an indicator for glycemic status actually, is crucial for enhancing diabetes management, as periodontal disease can impact systemic health by potentially worsening the diabetes control, and controversy elevated hemoglobin A1C level might aggravate periodontal conditions. Therefore, our aim was to show the need for regular oral checkups among patients with hyperglycemia to integrate oral health into managing their diabetes status. A clinical question is, how does abnormal hemoglobin A1C level affect periodontal outcomes? We chose the PFR framework for that, where our population is again a general population, including the normal and hypoglycemic patients as well. The prognostic factor would be the different levels of hemoglobin A1C levels, and the outcomes would be the different values of periodontitis, like bucket depth, clinical attachment loss, bleeding and probing, etc. And the hypothesis is that the stage of periodontitis is more severe in patients with higher hemoglobin A1C level. And again, my clinical implication for this project is to emphasize the importance of frequent dental checkups among patients with hyperglycemia and in normal glycemic patients as well. On this slide, you can see the progress of my second project. We are currently in the full text selection, as we had actually a large number of full text that we have to select, but we are working on it. For summary, I have 2 projects ongoing. My first one was first submitted this year in February, and for the 5th time in April. And my second one is under investigation. I hope to submit it in November this year. And for additional activities, I'd like to mention that I teach at my department under the supervision of my one of my supervisors. I teach in German and Hungarian languages mainly, and do seminars in English language as well. I had the opportunity to attend at conferences. I am incredibly proud of my basic research and the team of the basic research. We had a conference. We attended at the conference in the University of Split last year at the Regional Biophysics Congress, and we won an EBSA bursary for that. We attended the Semmelweis Symposium last year also with a poster presentation. We won the Best Poster Award for that, and we are doing presentations at the scientific meeting of young diabetologists and those who are working on diabetologic topics here at Semmelweis University. And I am an active member at the annual consultations and screening for patients with diabetes at Egy Figyelem Alapítvány. And I am a proud co-author on these projects as well, as we work as a team and we help each other with the investigations as well. And I'd like to finish my presentation with a quote from Louisa May Alcott from Little Women: "No good can come from doing nothing, as I am not a fan of bystander effect." Thank you for your attention.
Thank you very much. Okay, so I would maybe like to ask you on the point of novelty, okay. Especially for your second systematic review, what is it going to add to what we already know?
Yeah, thank you for your question. Actually, I had this presentation for 5 progress reports and no one asked this, but it is actually quite an important question. When we look into the recommendations regarding oral surgeries and periodontal complications in the perio journals, we find that there are no one value that they recommend to do in implantology or something. So in Hungary, we say that 7% of hemoglobin A1C level is the critical value. In Germany, they say it's 8. So there's no consensus between the countries, and I'd like to see if we could make a recommendation regarding these.
Okay, so it's the quantification of the increased risk for this parameter.
Hyperglycemic patients, yes.
Okay, okay, great. It would have been nice to include that. You know,
yeah.
Okay.
In the second study, do you think that it would be important to separate the different diabetic patients, so insulin users, non-users, and the different type of diabetes?
Yes, and we plan to do so. We integrated it into a Prospero registration. As you see, my second project started 1.5 years ago, but my selection is still in progress because I did it once. We changed the Prospero like it was by Petras based on the recommendations of my statistician. So we included this type of analysis into that as well because we'd like to do subgroupings regarding the diabetes type and regarding many other factors that we forgot for the first time, but we found interesting by the preliminary research as we continued with that.
And there is enough data for that?
I hope so. I think it will be. I found enough articles to make subgroups regarding these topics, so yeah, I hope so.
And one technical thing, so in the first studies, you have your effect size as the R square. Could you interpret it as
it means that only 5% of variance of salivary glucose levels could be explained by the changes of blood glucose levels. So yeah, so that's why the R square value with a 0.05 is actually a sad outcome for us because we hoped for a much higher R square value in this case. And in the second plot, in the scatter plot, it was 0.11, which is 11%. Still not what we hoped for, but better.
And the one
so it's a coefficient of determination, if these was the words that you were looking for.
Yeah.
Okay.
And another very technical thing, maybe I have to ask the statistician, but he's not here. So it's this IPD-based model. It was done based on the IPD data directly, or first the correlation coefficients was calculated and then pooled?
Actually, I had to extract the IPDs manually from articles based on the graphs. They included R square values, but after I remeasured it, it wasn't always the same that they reported it. And yeah, well, Gergő meant that maybe we could do our analysis because it's much more precise in our opinion.
Okay, thank you.
Thank you.
Can you go back to the goal of your first study?
Yes.
Maybe it's too late.
Mm-hmm.
But I would recommend a little bit rephrase the aim. You won't ever be detect a potential new method by a meta-analysis. You will develop.
Yeah.
I mean, so there are regulations, quite strict regulations, if you want to develop an in vitro diagnostic device, being a laboratory test or an point of care testing or whatever. So I think that is the development phase. You can, I mean, find an association or something that feasibility, but not.
Yeah, but not the method. Yeah, right. Thank you.
Thank you for your presentation. My question is regarding this topic. Was there any, or how long was the fasting period before the oral salivary sampling?
Oh yeah, you checked the fasting time. Yeah, it was at least 8 hours or overnight fasting, and it was based on the recommendations of one of my supervisors, as we hypothesized that maybe if we check the base levels, so no confounding factors like postprandial changes in the glucose levels could be a good first start. And if it would have been a much better correlation, that maybe we could have been investigated the postprandial like 2 hours or 3 hours fasting time. Yeah.
Okay, thank you.
Thank you for your presentation. Did you investigate what factors may have contributed to the extreme heterogeneity?
Yes, and it took a long, long time till we found an answer for that. We first checked actually the sample taking methods, they were very well described and there were no underlying factors in it. But when we went to the sample storing things like were they cooled, were they centrifugated, how did they collect them, what was the volume of it, it was a mess. Because sometimes they mentioned, okay, we used pre-chilled tubes, some of the articles used just less cups, some of the articles chilled the sample with the tube and put it on ice. Yeah, so the only common in these articles regarding this was that they used the glucose oxidase method, but the other ones were quite a mess.
Congrats for your presentation, Kata. My question would be that what do you think about the parotid saliva? Is it a more reliable method to reflect on blood glucose level than the whole or mixed saliva? What do you think, or what do you read about?
Yeah, thank you for your question. As I mentioned, we found in the literature that maybe if we investigate the parotid saliva samples, it could give us a much better correlation, and it is based on that it is more serious. It contains less enzymes like amylase, and it does not have the contamination that the mixed saliva or submandibular saliva has, like gingival cervical fluid, the bacterial glucose consumption, etc. So yeah, I think it's more reliable, and what's more important, it is actually quite easy to collect saliva samples from parotid because, yeah, as dentists we have to fight against the constant salivary flow in the mouth when we are working, and it is actually quite easy to collect it from the mouth without having it triggered.
All right. Can you go back to the first forest plot you presented?
Yes.
But before I ask, how do you define an outlier? What is an outlier?
An outlier is an extreme value, actually, that does not fit into our measurements.
Doesn't fit in my measurement in which way? Like, if I look at your forest plot, is there outliers here? Any study is considered an outlier?
Yeah, I think my first one, the Wang, is actually an outlier. Yeah, that one for sure. And the Tsui and Nirmala as well were outliers in my topic. They were above my 95% confidence interval.
Yes, exactly. So it's about the confidence interval, if they fall within the overall confidence interval or not. So my next question is, what's the difference between your first study and your last study? Could you find any specific characteristics that can affect your results?
Yeah, actually, in where it is a higher mean difference, like in the work of Tsui et al., they used newer methodology, newer laboratory technologies than they used in the Wang's methodology. Wang's is actually similar to, I think, it is included somewhere. I have an article that is actually quite old, and they had the same methodology actually, which was surprising because actually almost 20 years passed from the methods before, but they didn't change it. They just enrolled a bigger number of population, and they used it as a basic. Yeah, and in Tsui et al., actually, if I go to the scatter plots, you see the good correlation on this plot that has a quite good score. I think it's 0.9. I can't see it from here, but as I remember it's 0. It's the Tsui, so it was much better in sample taking, sample staging, and describing the methodology and observing the underlying factors behind. They did include important health data, like they excluded Sjogren syndrome, which is when you have reduced salivary flow rate, and they excluded them because actually it wouldn't give us a really good measurement. Yeah.
Thank you. And yes, my other question was, did you think about any possibilities to perform subgroup analysis? You have a good number of studies in your forest plot. Was there any ideas about any subgroup analysis?
Well, actually, in this case, we didn't investigate subgroups as we couldn't find any good reason to do subgroups. I know there's difference between the different types of diabetes mellitus, but as I mentioned, we worked with the general population, so we included the normoglycemic and patients with impaired fasting glycemia, and we just did one pool to check if there's any correlation between the two values, salivary and blood glucose levels. So this is why we wanted to see if there's any, and if there's not or not significantly high enough, then we didn't go deeper into this project.
Right, thank you so much.